All right, so we're going to talk about the spinal cord emergencies. This is a boring, really boring topic after lunch, but we have to cover it though. All right, so what are they? So the spinal cord emergencies are acute spinal cord condition threatening neurological and neurological function that requiring immediate intervention. And early recognition and management can prevent permanent disability and also death. So we'll talk about the classifications of the spinal cord emergencies. Traumatic spinal cord emergencies, we call SCI in the ICU, right? Vascular etiologies are infarctions, hemorrhage, also compressive hematomas can cause spinal cord emergencies, and also infectious etiologies, epidural abscesses, transverse myelitis, these can cause spinal cord emergencies as well. Transverse myelitis can be inflammatory or infectious etiology. Other inflammatory processes can be multiple sclerosis, and neuromyelitic optica spectrum disorders can cause spinal cord emergencies as well. Neoplastic compressions, whether it's a primary tumor of the spine or a metastatic lesion, can also compress the spine, giving spinal cord emergencies. So let's talk about the traumatic spinal cord injuries. Causes of these, we see a lot in Texas, motor vehicle accidents, we see patients coming with this, falls from the roofs and ladders, we see this, and also sports injuries once in a while we see. Objects, tree falls very common, especially here in East Texas, tree service personnel come with limbs sitting on their limbs, lumbar region and coming with paraplegia. So this is actually a picture of our own state governor who had a very unfortunate event about 40 years ago in 1984 when he was jogging. I think, he had a oak tree, a branch came and snapped and hit his lumbar region, and he became paraplegic for the rest of life, right? So we know about that, unfortunate. So pathophysiology of traumatic spinal cord injury, primary versus secondary injury, we'll talk about that. What is the imaging choice of imaging is CT versus MRI. We'll talk about that. So the management is initially, as soon as the patient comes, immobilization is very important. Sometimes we forget this in the moment. It's very important. Cervical spine with the C collar, or even thoracic spine, lumbar spines. We have stabilizers now with the belts and other equipment to keep the spine stable. High-dose steroids is not really, it's a controversial, for the TBI, the traumatic brain injury. For sure, we are not using any steroids, right? That's a big no-no. But spinal cord injury, some use it, some don't, but it's still controversial, high-dose steroids. Surgery, is whether it's surgery or not, we have decided that most of these patients end up being in a surgical candidate, and it has to be fast, right? That's why it's called emergency. airway is very important. We'll talk about that. When these patients will come with especially the high cervical spine injuries, the airway is very important. Sometimes these patients are talking to you, doing well, except for their deficit, and then airway is protected, but over sometimes hours and days, they can deteriorate, and then all of a sudden you lose the airway. So sometimes these patients should be intubated early, so they won't lose the airway, right? And also goes with sometimes these patients come with the cervical spine injury, crush injury, and then you do the decompression and fusion, and they come intubated to the PACU or the ICU, extubate them. This is not a typical patient who would rush to extubate, because these patients can have that secondary inflammation later, and then now you're struggling. You take the tube out too soon. Now patient is losing the airway, so we are going to try to struggle to intubate them again. So now you have a patient with fused cervical spine. It could be a difficult airway. So we have to think about those things. So all these guidelines I got from American Association of Neurological Surgeons and also AO Spine Global. All right, so let's talk about the primary versus secondary injuries. So the timing of primary injury occurs immediately after, obviously, right? Time of the trauma. And it's a direct mechanical damage, the shearing or the tearing or the crushing injury to the spinal cord. It's also, axonal disruption, vascular damage. Most of the time, this is irreversible. And you lose the function immediately right after the injury. Secondary injury develops, as I just said, hours to days sometimes. And pathophysiology cascade is ischemia, inflammation, and you have the potential to intervene and mitigate that damage. So those are the people that we can save, if you get into it as soon as possible. So the pathophysiology, again, the excitatory, cytotoxicity, inflammation, edema, and oxidative stress. So ongoing damage and worsening neurological deficits can happen over time, not immediately. So you have to very carefully watch these patients in the neuro ICU. All right, let's talk about the MRI versus the CT scan. So look at this CT scan, right? So these CT scans, so the patient comes with the paraplegia, quadriplegia. So you see something like this. You call the spine surgeon, the neurosurgeon, and tell them that this is what we have. The patient has quadriplegia, and you have this kind of CT scan. So the surgeon tells you, okay, get the MRI and call me back, right? What do you think? This is no-brainer, right? You doing the MRI? You need the MRI, but so you tell them, what do you say? Yeah, well, MRI is ordered and it's done. The screening is happening. Check is coming. The patient is typed and crossed, right? And NPO, we are ready to roll, right? This is not what you say, get the MRI and go back to sleep, right? So but you need the MRI, I understand. So what about a CT scan like this? So this is a patient that came with severe sensory and motor deficit, and CT scan read severe degenerative changes at C6, C7 with almost complete loss of intervertebral disc height, right? CT was reported as negative for acute injury. So you see that between the C6 and C7 right there, there's no intervertebral disc right there. This is how the CT scan will look. But MRI of this will look like this. So that's a whole different story in this scenario, right? So MRI, this is sagittal MRI showing complete rupture of the C5, C6 right there, intervertebral disc. And also you can see here the disruption of the anterior and posterior longitudinal ligaments here, C and the D right there. So this patient had on his MRI said moderate severe canal stenosis and had to go under surgery. So operative anterior fusion was performed and the patient regained satisfactory sensory and motor function. So we have to be careful. CT scan sometimes can tell us a story, but might need MRI. Some are very no-brainer. You can see it on the CT scan itself. All right, so the next emergency is the vascular emergencies of the spinal cord, vascular etiologies. So these are the spinal cord infarctions, spinal epidural hematomas, if you say, it's a vascular, because it's bleeding from the vessels, right? Vascular malformations, AVMs, and cavernomas, Dr. Welch talked about. I don't want to go too much into it, because really don't want to talk in front of him. This is, all right. I was really scared to give a lecture in front of him, when I was in training. I wouldn't talk like this then. I'll be looking at him all the time. What's the next question going to be now? All right. So spinal cord infarction. So the causes is atherosclerotic disease, just like MI or infarction, the cerebral infarction. That's the same causes with the atherosclerotic disease. It can be embolic or cardiogenic embolic. Or aortic surgery has given commonly spinal cord infarctions when you have open aortic surgery. So MRI features look like here. If you look at this sagittal MRI here, so this is a patient came with acute quadriplegia, and sagittal MRI here is showing that hyperintensity of the T2 imaging. It's not that clear, right? But if you look at the other one here, this is also sagittal MRI that's showing the area where the infarction is hyper intensity of the DWI imaging. And then here on this one, you see that the ADC is very dark. So the DWI giving very white and very hyper intensity, and the hypo intensity of the ADC showing us that infarction saying it's a very acute one, right? So these are not obviously surgical, right? So management is anticoagulation, just like in other infarctions. And then permissive hypertension. So the permissive hypertension for the spinal cord injury is usually not just 65. The MAP is usually, you want to do higher. It depends on the physician as well. 80, 90. Some I have seen go all the way up to MAP of 100 initially for a few days. Supportive care and aspirin and statin for atherosclerotic disease, obviously secondary prevention for ongoing chronic management. So the next is spinal epidural hematomas. We'll talk about that briefly. Causes, so anticoagulation just spontaneously can give epidural hematomas without injury sometimes. Traumas, obviously, and procedural complications. It could be something very simple like lumbar puncture or a pain injection or even steroid injections can lead to epidural hematomas that we have seen. But the consequences can be dire sometimes. So symptoms, if they come with any other spinal cord injury, right, the motor and sensory loss, usually bilateral, not always, but paresthesias, urinary retention, incontinence, constipation, then fecal incontinence, right? So saddle anesthesia is common with this. And then, for the management, these patients need emergent decompression versus we have to watch. Sometimes they get away without any intervention. Sometimes the symptoms get better. So we had to watch and very closely with the neuro exams in the neuro ICU, whether we want to do non-surgical supportive or immediate surgery. So look at the imaging here, as you can see. So the first one, can you guys see my cursor? No, really not. No? Okay. So the first one there is that actually actual CT scan that's showing the actual view. You can see that the dark arrows, that's actually a hematoma in the spinal canal, spinal cord pressing to the spinal cord, but it's not that obvious, right? But look at the next one to your right. That's the MRI showing the spinal cord is actually displaced to the front, as you can see, and then it's really compressed with the hematoma. Hematoma is shown with the white arrows there. So the sagittal view of this, the sagittal CT scan showing with the dark onto your left, it's not that really impressive, but look at the MRI, sagittal MRI, that's showing it really compressing the spinal cord with that hematoma. So the MRI is the imaging of choice for these. So the next thing is the vascular malformation and AVMs, all right, cavernomas, those things. So presentation is the same. It's a spinal cord emergency. They are presenting with a spinal cord deficits. Diagnosis, MRI can show these things, and the first one to your left is AVM, right in the spinal canal area, and then you also have cavernoma there. But these things, mostly actually better seen, just like Dr. Wells said that, the catheter angiogram, the DSA shows much better. You can see the fillings, right? So this one is actually a cerebral angiogram onto your right, with a left vertebral injection, and it's a lateral view, a large arteriovenous malformation there. You can see that it's arising from the vertebral artery. The arterial feeders you can see coming from both intracranially and also extracranially. So these patients, how do you treat them? So this is the spine, but I know Dr. Wells talked about the AVMs in the brain. So you're right. So he used to call this, you just let it cool off. That's what he says in these words. So if it is not really dangerous and it's not having immediate intervention needed, you let them cool off, right? But if you are bleeding, so you can go and endovascularly, you can coil them or do the onyx coiling or onyx embolization to stop the bleeding at the nidus. But eventually, if it is too superficial, you can do surgery, or as he said, gamma knife or cyber knife, outpatient basis, oncology radiation. But most of these actually observation is better than intervening to these things. And surgery is very rarely done on this anymore, unless, as he said, very, very superficial. So the infectious causes, acute transverse myelitis can present with spinal cord emergency, and then the osteomyelitis can lead to the transverse myelitis. Epidural abscesses from post-procedural, as we said, can give epidural abscesses. Also, IV drug use, from the hematogenous seeding can lead to epidural abscesses and compressing on the spinal cord. Immunosuppression, people can come with infections and epidural abscesses, and infectious causes causing the spinal cord emergencies and compression. So the management of these blood cultures is important to treat, what you're treating to. And then surgical debridement with cultures may be indicated if it is really compressing on the spinal cord and giving symptoms. Broad spectrum antibiotics, and then ID consultation is important, and also transesophageal echocardiography is important in these patients to rule out endocarditis. Right, so these are the pictures that, different infections that can look like abscesses and hematogenous seeding, or whether it's come from contiguous spread from the osteomyelitis. All right. So inflammatory processes that lead into spinal cord emergencies. Multiple sclerosis is inflammatory process. It's autoimmune demyelinating. So these patients, the multiple sclerosis usually is a chronic disease, but you can have relapses giving spinal cord injuries, emergencies, right? So high-dose steroids is the choice of first treatment for these patients. And then disease-modifying therapies like interferons, obviously, for the prevention and for ongoing chronic management. These patients are not definitely surgical candidates. Neuromyelitis optica spectrum disorders, transverse myelitis can present with that, as well as its inflammatory type, non-infectious type. Distinct from multiple sclerosis in that they are anti-AQP4 antibody attacking the myelin sheath of the spinal cord. So relapse management, the relapse again can come as a spinal cord emergency. So here is not the high-dose steroids. The first-line therapy is plasmapheresis, and again, the disease-modifying therapies like rituximab for the management of the chronic and relapse prevention. So if these patients show up in the ER and we don't know what we're dealing with, we admit to the ICU, and if that place don't have a plasmapheresis, you're stuck with the patient, right? Not because we are stuck with the patient. Patient is stuck with us, I guess. So you have to find a place to do plasmapheresis, and you need to know what the patient has. We have to transfer. It's easy to transfer from ER rather than transferring from ICU. So that's why it's important to know. This had happened. So these pictures showing those demyelination in those hyperintensities of the sagittal MRIs. All right. So neoplastic etiologies. Let's talk about that. Cause of neoplastic compression can be metastasis from lung, breast, prostate cancer. Common, have you seen prostate cancer metastasis? Lung, breast, all common actually to the bone and then pressing on the spinal cord. Primary spinal tumors can compress on the spinal cord, giving spinal cord emergencies. So the symptoms, again, back pain, neck pain, progressive weakness, sensory loss, sphincter dysfunction can see on these patients coming with the spinal cord compression. Imaging, again, MRI with and without contrast is the cornerstone of imaging in these patients. Treatment, high-dose steroids initially, and then the surgical decompression is probably indicated. Radiotherapy, as Dr. Wells said, we are not doing radiotherapy in emergent patients, very unlikely to do it. Here we do outpatient as an elective for other things, not for like this. So radiation therapy for these are not really routinely done in any institution that much, I guess. All right, so this is the case, really quick, I'll talk about. This is a case that I was involved and I am very aware of and involved in actually. This is not in this hospital system, it's a different hospital system. This patient is a 78-year-old male with a history of chronic back pain and neck pain and dependent on a walker for ambulation at home. Patient's neck and back pain chronic and has presented to the ER many times in the past to the same hospital. And this time presenting with the fall and worsening neck and back pain. So this time it's coming with a new right arm drift and 3 out of 5 strength on the right arm. So the CT scan, if you look at the CT scan, the one to the left is about a month ago. CT scan showing that there's a small mass there, encroaching the spinal cord a little bit, or the area around it, but people missed it, right? Or the reader missed it. But to your right is the today one after 1 month. The patient is coming with the same the worsening symptoms and have that mass there. That now you can see that is actually encroaching and kind of like invading the spinal canal. So when you saw that, they went back and looked at the 30 days ago. Then only they realized, so there was it that was there before, right? This retrospective, and then on this CT scan you can clearly see that axial imaging that it's definitely coming to and approaching the spinal canal. So the CT scan read soft tissue swelling mass extending into spinal canal with epidural component narrowing the canal, most notably at the C2, C3 level. And so the reader recommended further evaluation with MRI. So MRI with and without contrast, as I said, stat ordered. Neurosurgery was consulted. Neurosurgery was not available on this satellite campus on this hospital system. The main hospital system is in the downtown. So the neurosurgery was consulted to transfer, and the surgeon said, yeah, transfer, but get the MRI first before transferring, so the MRI will happen soon. MRI was done, however, patient arrested, had a cardiac arrest and got intubated. Patient had cardiac arrest because this was pressing on the high up C2, C3 level. Patient had a respiratory distress, respiratory arrest, and led to cardiac arrest. That's why patient had the cardiac arrest, got intubated. MRI was done, transferred to the main campus. The neurosurgeon and anesthesia said, we need cardiology clearance because the patient had a cardiac arrest. What do you think? Right? Cardiologist said, we need the echocardiogram to give the clearance. And that was Saturday, Sunday. And then echo was done, MRI was read, and the cardiology waited until the echocardiogram was read by another cardiologist. And then it was, finally patient was cleared to go to the OR. Yet it took one more day because it has to be a weekday, next day, and patient went to the OR after elective surgery done, okay? So the patient was quadriplegic by the time of the surgery and never recovered, okay? So biopsy confirmed this is a large diffuse B-cell lymphoma. Surgeon wrote on follow-up progress note that on repeat, depending on the, based on the repeat imaging, excellent decompression. And oncology commented saying that early recognition and intervention would have provided excellent prognosis with available therapy for large B-cell lymphoma. But patient never recovered and became permanently quadriplegic. And he eventually decided to transition to hospice care, and he was very well with it because it's all down here, right? He was very well with it. He decided, no, this is not how I want to live. So he eventually went to hospice care, and then soon after taking off the ventilator, he died. He passed away. So I'll let you decide where we missed something, if we missed something, right? So, all right. So the summary and key takeaways from my, this little talk here is the rapid diagnosis and early intervention are very critical in spinal cord emergencies. And MRI with and without contrast is the cornerstone of diagnosis of these spinal cord emergencies. Treatment is etiology specifics, as we talk about, and often multidisciplinary. So that means we need the neurosurgeon, neuro-IR, neurology involved, infectious disease if it's the infectious cause, right? So it's multidisciplinary, and secondary insult can be delayed hours to days, as we said, airway. Sometimes we get these patients intubated empirically early, and if you decompress them, high cervical spine, don't rush to extubate them. Give some time to get that injury cool off, because that edema swelling can set in later, and then now you have a, patient is losing the airway. So this is another thing. The chronic insidious spinal cord conditions can present with sudden acute exacerbation. So this is another thing that we miss. So the patient, let's say months, years, patient has had symptoms, patient presents with now acute exacerbation, symptoms are worse. So we tend to say, oh, this patient had this like months before. This patient has this years. Sure, but now the patient comes with the acute exacerbation, things can go downhill fast in this situation. You don't want to sit on that, right? The patient present to the ER, the hospital for a reason. Now in inpatient, probably can go down, even though it's the same problem that causing the issue acutely. So you need to get to it soon and get an MRI stat and then go to do what next to the management. Differentiation between the brain and spinal cord etiology, that's another thing that sometimes we miss. I'm not saying that we do that all the time, but stroke versus spinal cord injury, how do you know, right? So stroke, if it's a head bleed, we know CT head will tell us this is a bleed, right? What about the strokes now? So strokes are sudden, right? Onset and usually no precipitating event, right? Often unilateral weakness, right? And sensory or deficit, motor deficit, speech or vision deficit, and then you have, dysarthria, aphasia, things like that, facial droop, cognitive impairment, and ataxias. So what about the spinal cord emergencies? So they usually, sometimes, not always, bilateral, it could be bilateral, motor sensory deficit, right? Below a certain level of the spinal cord innervation, right? Also the autoimmune dysfunction, so autonomic dysfunction, I mean, that you can have elevated, rapid fluctuations of blood pressures and heart rates. So that could be something in the higher spinal cord. Bladder and bowel involvement, usually spinal cord, right? More than the brain, right? And usually no facial involvement, no dysarthrias, no aphasias, no facial droops, no cognitive dysfunction, right? No speech impairments. So we need to differentiate that, because if you have a patient that you come, the CT head is negative, no blood, let's give TPA, right? TNK. Now you realize, okay, you get the CT angiogram to rule out head and neck, LVO. Now you see, oh, look at that. What is that in the CT, C-spine? So now you're stuck with that. You get TNK. You need to go to emergent compression, decompression to the OR, right? So So I'm sure we know how to differentiate those things. I don't have to insult you like that. It's okay. Right. So the references I use for this presentation is latest guidelines from American Association of Neurological Surgeons, Congress of Neurological Surgeons, and also AO Spine. Global key studies and meta-analysis that I use are these. So good luck reading those. It took like 6 months for me. All right, guys. Anything else? Do you guys have any questions for me? No? Good. Thank you.
Lily, so yeah, it's okay.
Oh.
Yeah, so, yeah. No, I was going to say it's a good corollary to what we talked about this morning, and I just want to really reiterate that when you see those images that he showed for the spinal cord edema, those are the ones I was telling you are 6 to 9 months before they actually get diagnosed with the fistula. And the transverse myelitis fistula overlap, there's a lot of patients getting treated for transverse myelitis, or there's a number of patients being treated for transverse myelitis who are found to have fistulae, and they just didn't get good spinal angiography. So doing a good spinal angiogram, what we've started doing now is, it's called a twist MRA, but it's a really specific MRA to kind of hone us into where we may see the fistula, and then we can go, because if you think about a spinal angiogram, if you're charging for it, it's great, but it's, 12 thoracic, 5 lumbar, upper cervical, right? And you have to look in each one. So patients they get a lot of dye, if they have kidney disease. So if we start, but think about that, if you're going to get the MR, ask them for a twist MRA, right? But a long cord spinal edema, to me, is transverse myelitis eventually, not as the first diagnosis. So
You do MRI and MRA, just MRA?
I'll do MRI, and then I'll do the twist MRA, and then we'll go to angiogram and look, 3 above, 3 below. But that's a lot less than 26 levels, right? So, yeah, but those are good pictures of that.